My name is Justin Powell, and this is the last PowerPoint. We're going to talk about antihypertensives, some common antiarrhythmics, and vasodilating agents. Let's start with the next slide. Beta blockers. So, what I tried to do was pull through the top drawer of my drug cart and see what was some of the common drugs in there to bring to everybody today to discuss. Felt it was important to hit the ones most commonly seen. So, with that being said, in beta blockers, there's two classes, beta 1, beta 2. Why is this important? Well, if your patient has a reactive airway disease of any kind. So, what I see in the top drawer, that was beta 1 selective, metoprolol, esmolol, and atenolol. And let's further discuss what is beta selective and what's not. So I just told you what was beta selective, but the drugs you're not going to see very often that are not beta selective: propranolol, timolol, nadolol, sotalol. But one you will see is going to be labetalol. So metoprolol. This is a selective beta 1 antagonist which prevents inotropic and chronotropic responses. Plus, this drug is keeping your intact bronchodilator, vasodilator, and metabolic effects of beta 2 receptors. Note that the large doses will become non-beta 1 selective. If noted increase in airway resistance, beta 2 agonists such as terbutaline will readily reverse this. So dosing wise, it's recommended to start with a 5 milligram bolus and work your way up to 15 milligrams total and give yourself 3 to 5 minutes for your onset of action. Esmolol, wonderful drug, very commonly found in top drawer of your anesthesia cart. Well appreciated for its rapid onset and short duration of action. This is a cardioselective beta 1 agonist. And a little line from Nagelhout's text just states that this drug has an onset of 2 minutes and a duration of action of 10 to 15 minutes. Metabolized by your non-specific plasma esterase is found in cytosol or red blood cells. Moving on to labetalol. This is a non-selective beta blocker that possesses alpha blocking component. The beta blockade ratio is 7 to 1. The alpha blocking effect causes vasodilating effects. Bolus dosing with this drug is commonly used as 5 to 10 milligrams, with effects seen in 5 to 10 minutes, and this can have a long duration of action, up to 2 to 6 hours. This drug is recommended in obstetric patients as it does not affect uterine blood flow. Very important. Alright, next slide, talking about the overdose. Hope you never see it, but nice to know how to treat it if you do. Typical signs and symptoms: bradycardia, low cardiac output, hypotension, bronchospasm, depression of ventilation. What should you do? You should give atropine if you have any excessive signs and symptoms of overdose. If atropine's ineffective, then you're going to want to use isoproterenol. This is a pure beta 1 agonist, but oftentimes it's recommended, it's pure beta 1 and beta 2, Oftentimes it's recommended to go to dobutamine, which is a pure beta 1 agonist. The reason being, isoproterenol may cause vasodilation before its inotropic effects kick in. Very important note. Glucagon, you can give this up to 10 milligrams IV with 5 milligrams per hour IV to effectively reverse your myocardial depression produced by the beta antagonists at normal doses. Glucagon exerts its effects by second messenger stimulation through adenylate cyclase and increasing intracellular salicylic AMP. You can also give calcium chloride up to 1 gram IV, which can help offset any excessive cardiovascular depression you may run into. So calcium channel blockers, very common. Block the opening of calcium channels, resulting in a slowing of heart rate, reduction in myocardial contractility, decreased speed of conduction of cardiac impulses through the AV node, and finally, vascular smooth muscle relaxation. An important note here is that verapamil and diltiazem have potent local anesthetic activity, which may increase your risk for local anesthetic toxicity when regional anesthesia is administered. Verapamil. Major depressant effects on your AV node, has negative chronotropic effects on the SA node, negative inotropic effects on your cardiac muscle, and a moderate vasodilating effect on the coronaries and systemic arteries. Note, do not give this to Wolff-Parkinson-White patients. Very effective in the treatment of superior ventricular tachydysrhythmias, reflecting its primary site of action on the AV node. Onset of action is 2 to 3 minutes and can last up to 6 hours. Dihydropyridines. This class is a branch associated with calcium channel blockers. They prevent calcium entry into vascular smooth muscle cells by extracellular allosteric modulation of the L-type voltage-gated calcium ion channel. So drugs we will talk about in this class are as follows: nifedipine, nicardipine, nimodipine. All of these very important. Nifedipine, once again, is a dihydrodyne derivative, and once again, this means it also prevents calcium entry into the vascular smooth cells by extracellular allosteric modulation of those L-type voltage-gated calcium ion channels. This specific drug has greater coronary and peripheral arterial vasodilator properties than verapamil. It does not affect your SA or your AV node, very important. And due to a decrease in systemic blood pressure, baroreceptors will be activated and cause an increase in heart rate. Note, abrupt discontinuation can cause coronary artery vasospasm. Nicardipine. This drug is special because it does not depress the cardiac myocardium. This drug also has the greatest vasodilating abilities in its class, and the vasodilation is most prominent in the coronary arteries with this drug. Alright, moving on to the next slide. Nimodipine. I know you'll see this on boards, probably seen it before on your seat. Very important drug. Most lipid soluble in its class, allowing it to cross the blood-brain barrier. Now, why is that important? What's it most commonly used for? The answer, cerebral vasospasm, most commonly associated with subarachnoid hemorrhage. Benzodiazepines. Drug in this class, diltiazem. I know you've been pre-oping your patients. You've seen this drug, come across it. Well, let's talk about just a couple of important points here. This drug predominantly blocks the calcium channels located in the AV node. If you have an intraop issue, what is this drug good for? This drug is the first-line treatment for any supraventricular tachydysrhythmias. Special notes with interaction of calcium channel blockers. These drugs all have depressant effects on the myocardium. So once again, what if your patient experiences toxicity this time? Well, IV calcium or dopamine is what was recommended by Stotling. Verapamil can cause AV heart block and should be given with caution in patients who are treated with digitalis or other beta blockers. Okay. Next slide. Some special anesthesia considerations. So, the story here is your patient's on a calcium channel blocker, and you note for your anesthetic plan you're going to give this patient a Nectine as your primary paralytic. Well, what should you be aware of as the anesthesia provider? Well, the answer to this is that calcium channel blockers on both depolarizing and non-depolarizing relaxants are potentiated. They have a longer lasting effect, similar to treatment as seen with the myosin antibiotics with muscle relaxants. Note that whenever any calcium channel blocker or dantrolene is administered to your patient, given concurrently, it is imperative that the provider frequently monitors serum potassium levels and invasive hemodynamics as the two work together. Vasodilators, just a real important one I thought was good to include on here for a little review. Clonidine, important drug for multiple reasons, the analgesia, but also the antihypertensive effect. This is a central acting alpha-2 agonist, 220 to 1, alpha-2 to alpha-1. Decreases sympathetic nervous system by seeing peripheral vasodilation, drops blood pressure, heart rate, and cardiac output. Note that if you discontinue this drug very abruptly, you can have rebound hypertension in as quick as 8 hours or as late as 36 hours. Nitrodilators, just a couple here. Sodium nitroprusside is a direct-acting, non-selective vasodilator. It relaxes arterial and venous systems. Sodium nitroprusside it interacts with oxyhemoglobin and forms methemoglobin while releasing cyanide and nitric oxide. Dosing. Recommended to start at 0.3 mics per kilo with a max rate of 10 mics per kilo per minute. But if you go over 2 mics per minute, you risk cyanide toxicity, and you should weigh risk versus benefit in regards to your infusion. Let's talk about nitroglycerin. It's an organic nitrate that works on the venous system and large coronary arteries to produce peripheral pooling of blood and decrease cardiac ventricular wall tension. Produces nitric oxide, which stimulates second messenger cyclic GMP to cause vasodilation. Not recommended in patients who have aortic stenosis or hypertrophic obstructive cardiomyopathy. This drug also can cause methemoglobinemia. And finally, hydralazine. This is a direct arterial vasodilator, causes reflex tachycardia and increased cardiac contractility. Not recommended for anyone with coronary disease or an MI, and is a very effective afterload reducing agent. Phenoldiprem. This is the last drug. This drug is a dopamine 1 receptor agonist, causes arterial dilation while increasing renal blood flow and urinary output. You will see a baroreceptor-mediated increase in heart rate. And I chose to pick this drug because if you go to the NCE NBCRNA website and you start looking through some sample questions for boards, you will find a question on phenoldiprem. I thought this was nice to include. So here's my